In this section on shared decision making and goal setting, we're going to talk about how the case manager is involved in several key activities. We've already discussed assessing clients' needs and strengths, and now we're going to talk about how to create a service plan and monitor individuals as they make progress towards goals. Good service plans are clear, concise, and individualized, and of course coordinated with clients. They may also be coordinated with other staff members, other agencies, and external partners. So now we're going to just do a short review. We looked at 6 stages in case management process, or at least these were presented. We've looked in depth at engagement, which is the ability to establish a working relationship with clients. And we learned in engagement that it involves some outreach. And we also need to determine the client's eligibility so that we can enroll them if their fund source is Medicaid. We also look to see in engagement that other fund sources may come into play for case management services, and making sure that in the engagement process we're able to provide those services to the client. In assessment, we learned that that was a huge process. It's an interview we have with the client, and we can identify the strengths and barriers, which are then stated and summarized in both objective and subjective terms. The assessment process is a needs-based and holistic approach to talking with the client about what their needs are and how they would like to have those needs addressed. We talked about assessment in terms of a recovery model, and hopefully those were not new principles to you, but if they are new principles, you may want to go back and look at some of the handouts that were attached to the assessment training, and also review the recovery model PowerPoint video that is also included in this training. Now we're going to talk about planning and goal setting. Again, this is a process done jointly with the client and or his or her family members or other stakeholders who might be involved with the client. Later on, we'll talk about interventions and then how to monitor and coordinate the plan with the client, and then finally we'll talk about termination. From the assessment process, we gather data to generate a service plan. As a reminder, anything that's written in either the clinical summary or the service plan problem list should already be documented in either the assessment or the psychosocial assessment or a psychiatric assessment. No new information should appear in the clinical summary or the service plan problem list. We want to be able to explore with the client his or her family or significant others the full range of goals, and then establish specific goals. So we remember that the client is the decision maker. During the assessment process, we asked the client to sign release of information for people he wanted us to get information from. We may be thinking about that again as we've gotten to know the client better, and ask again, is there anyone else who should be authorized through that formal documentation? And then we may also want to consider, prior to writing a treatment plan or a service plan, to have a staffing and consult with some of our partners in the agency, or even some of the stakeholders who are already delivering services or working with the client to gather more information before we start the service plan. Again, we would think about, do we need a release of information for those folks? Collaboration is the case manager's middle name. It's what we do every single day of the year without even thinking about it. Collaboration is a deep, collective determination to reach an identical objective by working with others to achieve shared goals. That's a mouthful. But as case managers, we always advocate not only for the patient, but also for the providers, the payer, and in some instances the employers, to facilitate positive outcomes for the patient, the healthcare team, and the payer. If a conflict arises, the need of the patient must be a priority. A case manager's primary obligation is to his or her patient with the ideal collaborative practice. The positive patient outcomes of quality of care will be achieved. So collaboration is key. No matter what aspect of case management is your area of expertise, it's not an intersection of common goals, but it's sharing knowledge and building consensus. The most successful collaboration requires a leader, and since we're usually the only one in the team communicating with every stakeholder, the case manager is a natural choice for that team leader. The case manager should retain oversight over the entirety of an individual's situation over time. This gives a valuable sense of continuity for the patient, which is an important characteristic of any case management program. So as the team leader for the client, we would hold staffings, and these staffings might include contacting community partners with whom the client is involved or may be involved with in the future. And these staffings can be by phone. We can advise them of case management activities and determine their need for joint planning. We can also arrange formal meetings with all the partners this client may be involved with to staff the client and develop a joint plan. This could be a family, this could be different agencies who are providing services to the client, or in the case of children, it might be a school-based meeting where the teachers, guidance counselors, and others involved with the client would join together. Of course, we need a release of information for all of these individuals. So having an agency staffing to problem solve is another consideration, and that would be all the providers in the agency who are going to be working with or who are already working with the client come together, have a staffing to discuss how case management can help and support the client with these treatments. So consider the staffing the client with any programmatic staffing teams to access a wider range of services. To be able to create a successful service plan with the client, the case manager has to be the expert on the resources that are available in the community. The best way for a case manager to be the expert is to work with and in collaboration with the other case managers in the department and build a referral list that everyone can share. And it's really important to keep this referral list up to date as referral opportunities come and go. New ones will come in, some will close down. And it's also really important to know the criteria for all of these different referral possibilities, because one referral is not going to be the be-all and end-all for every client. So a case manager has to be aware of community resources that clients commonly use, know where to obtain information on resources for clients with special needs, and alert others in the agency of the need for new resources to meet these newly discovered needs for the client. It's oftentimes interesting the way referral information is gathered. You could do like a Google search, an internet search. Sometimes your supervisors and managers will learn of new programs as they attend community meetings, and they can bring that information back to you. Sometimes it's word of mouth, because one client will tell another client about a service they found or an opportunity, and your clients will end up telling you about different opportunities as referral sources. So keep all of these things in mind. Case managers can be more successful when they work together to share referral source lists and keep those source lists updated. Now we're getting to the nuts and bolts of actually creating a service plan with the client. We want to develop a plan that maximizes the client's strengths, minimizes barriers that the client is already experiencing, and these plans have to be objective and measurable. That means, like a behaviorist, we have to do a baseline count of what's happening now, and use words that are measurable and are countable, and then set a time for when this goal or the objective is going to be achieved. Having a time reference is really valuable to both you and the client, and the time reference should also be negotiated. Here's an example. When I was working with kids, I would ask them what do they want help with, and they would say, I really need help with my math. And I would have to explain to them that I was a therapist and that I was not a tutor, and what all that meant and what I could help them with. And so once they decided what they wanted help with, then we would have to figure out a time. So for kids, it's hard to figure out 3 months. What does that really mean? So we would do it in terms of holidays and school breaks, which was really helpful for the child to be able to conceptualize that period of time. So keep those things in mind. Keep in mind who you're working with, what their sense of time is, and how do they measure time, what's important to them. A thorough service plan is built of many steps that you and your client have already identified as being vital to success. So you're going to write each step in the plan and engage the client in this implementation of each step with timeliness and timelines and results recorded for each step. That's your documentation. For example, forms and applications for aid might be required to apply for various services you've identified as being vital. So the service plan may provide a week for the client to obtain and turn in those forms. Appointments might be made and kept, and all those are duly noted in the service plan. Include instructions for the client in the plan, as well as what steps you'll be assisting in completing. As we're building a problems list, we also want to identify strengths the client has and the strengths the client will use to address the goals and objectives that are going to be derived from the problem list. So the problem list helps define the goal areas in the conversation that we have with the client. And this problem list is, as I said, derived from the assessment data. When problems are being identified on a service plan, we may have to translate from the client's words into the language of the electronic health record and then back into the client's language again. For example, if you have an electronic health record, it's going to have categories of strengths, like the ones that are listed here. You have to take the client's words that are listed, the example on the left, in the left-hand column, and then pick a category that closely meets the client's strengths, and then print out in the description of that category, that strength category, the client's individualized strength. So let's look at this. For example, the first one, ability to read and comfort with reading. In this one, the client is saying that they're comfortable being able to read and they have the ability to read. So in the EHR list, we might pick abilities, open that up on the EHR, and then type in the specific ability that the client has, in this case, the ability to read and comfort with reading, because that's going to be a good strength That will come in handy as the client is trying to accomplish his or her goals. Let's take a look at the next one. Comfort in initiating social contacts. That may not be really the client's words. They might say, I'm really comfortable meeting people and have lots of friends. So if we look at the EHR list of strengths, we might pick openness. We also might pick acceptances. In some EHRs, that opening up these categories may have descriptions that go with them to help us decide whether we want to use acceptances or openness. Either way, once we pick a strength, we can then type in the individual strength in the client's own words. Let's look at the next one. A supportive significant other and a supportive boss. Which of these strengths might we pick for that? It might be level of insight, depending on the nature of the support the person's getting from their significant others and bosses. The person might have a level of insight to realize that having the support is going to help them attain their goals. The interest in healthy leisure activities also might be a level of insight. It might be a history of treatment compliance. So again, we have some options when we're creating this list with the client and with the EHR. The electronic health record may also prompt you to identify barriers to services and treatment. And in this case, I've put the EHR categories on the left-hand side, and we can match up the individualized barriers on the right-hand side to some of the categories. For example, an inability to read or a difficulty in reading. If we look through the list of potential categories, we might put that under educational. How about shyness? That would probably fall under an emotional barrier. Family history of substance abuse disorders could fall under familial barriers. Failure to succeed in group settings might be an interpersonal problem. And you can see how these categories then can be opened up and then described specifically with the client's particular barriers. Service plans are developed during face-to-face meetings with the client and negotiated between the client and you, the case manager. You have to encourage the client's active participation and empowerment. Then a copy of the service plan will be offered to the client to emphasize the partnership necessary in this case management process. Measurable goals and activities take into consideration cognitive and physical abilities of the client, the available resources, the support networks already in place, and some that the client hasn't thought of yet, and of course the client interest. These result in a more realistic and client-specific plan. Although client signature denotes acceptance of a plan, a client may decline all or any portion of the service plan. Documenting these changes and these incidents, such as the client not wanting to sign the service plan, is part of successful documentation. Family members and collaterals may assist in ensuring clients receive the services that are in the plan, and they can be then included in the service plan as identified to help carry out the activities. So mutually developing the plan with the client, and we're using the assessment and different staffings we may have had and the referral list that we have to help create this plan. We determine long and short range goals. Short range goals are those intermediate steps to achieve the long-term goal. We may include employment goals when identified by the client as a preference, and employment goals should be based on the client's skills, their job history, and abilities. We might identify activities to address the short-term goals, and we will prioritize the accomplishment of activities with our time frames. We're going to establish these time frames for the beginning and for completing the activity. We're going to determine what resources the client, the agency, or partners can use to support this activity, and then we're going to outline how the plan will be coordinated with partner agencies. Service plans are one of the most important tools to utilize when attempting to engage a client in services. Service plans should be collaborative, creative, and a client-driven activity between the case manager and the client that focuses on the client's view of their stated problems. The focus of a client-driven service plan is on building a relationship between the case manager and the client. This alliance generally begins during the assessment phase, and the relationship is strengthened or strained based on the level of buy-in the client experiences in this service planning stage. A client-driven, individualized service plan is the basis for doing good service and gives the client a sense of accomplishment and success. A successful alliance hinges on 3 factors which must be present, along with qualities like rapport, which we talked about in the engagement process. So these factors of successful alliance include an agreement on the tasks and goals of the service plan, right? Agreement on the methods that will be used to achieve those goals and tasks. And then the client's perception that the case manager understands their problems in the context of their own life. The service plan itself is a structured document that lists problems first. So the client has already described the areas of concern and the obstacles to overcome, and those were collected in the assessment. We can now create a problem list with the client and check off the problems that we can help the client with, because as in the example previously, a client may identify problems that are not really problems within the mental health or substance abuse field, and we may want to consider how else we can help that person with those particular issues. However, they may be problems like in the previous example where the child wanted a tutor. So as a case manager, we could include that on the service plan to link the child and family with tutoring. Next, we define a goal. A goal is the long-range thing that the client wants to attain. And the underlying premise of goals is to support the client so that they become self-sufficient, more independent, and better able to manage their own conditions themselves. At first, clients come in, and one of the requirements by Medicaid is that the client cannot get services or link to services themselves, and therefore needs a case manager to help them. And we have seen that in the process of providing case management, that we are helping the person develop these skills over time, so that by the time of termination, the client may actually be able to, the client will be able to link to their own services and know the resources out in the community, and they won't need case management anymore. Objectives are measurable steps that can be taken to reach that long-term goal. These steps are based on the strengths the client already owns, and they're stated in a language that the client understands. The interventions are the things that we as case managers are going to do, including brokering or collaborating on the client's behalf, linking the client to resources, advocating for the client, and coordinating services. Goal setting is a shared decision-making process we conduct with the client. We want to maximize the client's strengths in attaining the goals that the client decides on. We want to minimize the barriers to attaining those goals. Let's look at the first step in service planning, which is describing the problems the client has identified and which we ascertained in the assessment process. We want to be sure to use the service plan to focus on current problems. We may have talked with family members or others who may have referred back to issues in the past, so we want to be clear on the problems that are occurring now. The problems list is developed from the assessment data, and the list is used to focus on the client's current areas of concern and the most immediate areas of concern. This problem list is the basis for the plan. Problems on the service plan are taken directly from the problem list. A problem is a need of improvement, and it's a concern that is current. Common mistakes providers make is listing a statement of fact instead of a problem in need of an improvement. A statement of fact is something that was true in the past. For example, a client might say, "When I stop taking my meds, I feel like using." It may be true if someone is not currently taking meds, or if their meds are not being taken as prescribed. However, once someone comes into treatment, they have gotten back on their meds, and so therefore, in that situation, it would not be a problem that's relevant. If you think you have all the problems listed, you might want to review the assessment and ask yourself these questions as you review each section of the assessment. What were the weaknesses identified in this area of the assessment? Is this a problem related to the primary diagnosis? And have I listed all the problems identified in the assessment? Is the problem clearly stated, and is it concise? Is it in the client's words? When using the electronic health record, many program templates have the service plan set up so that when the problem title is identified, the goal selection is generated. Check your electronic health record to see if that's true. You will have to become familiar with the particular electronic health record your agency is using. The case manager will then need to individualize each problem and each goal in the notations area. Sometimes it's called the description. It depends what your template you're using. So take a look at that, and your supervisor can help you with that. Determining service plan goals. The client ultimately determines the goals. However, the case manager uses his or her interviewing skills to help guide the client towards a goal that's achievable and pertinent to the diagnosis and the particular stage of change. Goals are individualized. This means that they're specific and they're applicable to the client's needs and abilities. The client should be able to see how working towards the goal will help to resolve the stated problem. This gives the client a sense of self-esteem and helps them feel that they have accomplished something worthwhile towards their focus of treatment. It is important to create a goal that's not simply a restatement of the problem. Goals are related to the problem, but they're opposite of the identified problem, and they're logical outcomes of an action step. The goal is current, the goal is informative, and it's relevant to addressing the problem. The goal should be stated in measurable terms using action-oriented language to illustrate a direction of change. Let's take a look at the screen. I have on the right-hand side SMART goals. This is an easy way to remember how to compose goals. Goals should be expressed in the words of the patient so as to be understood by the patient. Goals reflect the client's age, development, culture, and ethnicity in the way that the goal is constructed. Goals are responsive to the client's disabilities, their disorders, or their concerns. Goals should be achievable. They are time specific. That means you need to have an end date for reaching the goal. Goals are appropriate to the service setting. Goals are identified so as to use the patient's strengths to achieve the goal. Here are some cues to help you in your conversation with the client in determining goal statements. You might ask the client, what would be the solution to the identified problem? Or you might say, what would you like to obtain so that recovery is possible? A really good question is, how would you know the problem is solved? Remember, the goal is stated in the client's own words, and each goal has a target date, which is the expected date of completion. Let's take a look at this suggested problem and goal. Let's say a person says, I'm not sure I want to stop using drugs, but I know my brother is threatening to kick me out of his house. So what we're hearing the client say is, I'm not sure I want to stop using drugs. What would be the solution to this identified problem? Or how would we know from the client that their problem is solved? So we might have that conversation with them, and in that conversation we might find out from the client that they're willing to try to understand all that they can about addiction to see if they buy into it or not, and then they'll make a decision whether they want to stop using drugs. So the goal stated in the client's words could be, understand all I can about addiction, and we want to make it time limited, so we're giving the client 3 months because that's how long they have told us that they would need. We may find that they would accomplish this goal much sooner than that, which is fine, because we're going to be assessing this goal every time we meet with the client, and when there's a significant change, we'll update the service plan. But 3 months is an adequate amount of time, since that's what the client's asking for. The note about this client is that they could be assessed as being in the contemplative stage of change. They're not really sure that they're ready to change, although they're recognizing that there is something that could be a problem, but they're still not believing that in this case they have an addiction problem. So the client begins to consider that he or she may want to overcome the problem, but at best they're still ambivalent. So our service plan would probably be conducted in the direction of helping the client decide if they want to move to the next phase of the stage of change. Regarding the issue of short-term goals versus long-term goals, keep in mind that long-term goals are generally for treatment modalities of 6 months or more. In other words, try not to use goals that require extended time frames to solve a problem. Help the client choose goals that are realistic and obtainable within the current level of the service plan. This supports the client to experience a successful and positive view of their services and gives them the motivation to move successfully through the continuum of care. Turning now to objectives. They are action steps that are the nuts and bolts of the treatment plan or the service plan. They are the specific elements that combine to produce a change for a given problem. Like problem statements and goals, action steps need to be current. They need to be relevant to the client and achievable during the episode of services. Action steps are better if they are informative of the treatment, and they should explain the direction of the service and not just be a list of things to do. So if we think about objectives as SMART objectives, they are specific, they are measurable, they're attainable, they're relevant, and they're time-based. An objective, as we have noticed, is a stepwise method to accomplishing the goal which resolves a problem. Objectives can also be thought of as an assignment. This is an assignment you as the case manager and the client have devised together. Objectives are tasks. They're behavioral tasks that the client completes as a step towards achieving the goal. In an electronic health record, Each activity or objective is associated with a goal, though the goal may have more than one activity. Briefly and simply state the activity. Note a target date, note a responsible party, in this case the client, and the progress or outcome that's expected. Here's an example. Enroll in a smoking cessation program. The target date would be February 15th, 2020, or a current date. The responsible party is Jim Taylor, the client. A progress note then is documented to the effect of Jim came to our appointment and had a printout of possible programs from his online search of smoking cessation programs. We identified the most convenient options, and I, the case manager, will also investigate referrals. That might be a progress note in a future session once this goal has been established. The characteristic of a good objective is that it's simple, and it's small enough in nature so that it can be easily accomplished. It's specific. When you're using an electronic health record, the treatment plan or service plan that the electronic health record provides you generates goal and objective areas. So like when you pick a goal, it will perhaps have a drop-down menu of objectives that you could choose from. These are canned objectives, and so you have to make them individualized for the client. And there's usually a box where you can type in the specifics that pertain to the client to make this objective more individualized. Objectives are active. That means they're something that can be done now for the current problem, and they state who's responsible for verifying the completion of the objective. So the client's going to complete the objective, and it might be you as the case manager who verifies it, or perhaps it's something where the client is going to go get signed evidence or a piece of paper from someone else or a list from someone, and you might want to identify who that is. The objective will identify frequency, how frequently this is going to occur, or if it's something that's being eliminated, it might have a reducing frequency from something that happens a lot to something that happens a little. The objective has to be connected to the goal, and it's supposed to have a due date. We've talked about how it's got to be measurable, and it's best if it measures just one variable. So if you have something that you notice is measuring a couple of things in one sentence, you may want to think about breaking that up into several objectives. So the objective is like an assignment for the client, not really for you, the staff. This list of measurable terms for objectives will help you write a good objective. So if you start with one of these verbs, you'll probably be able to write a good objective with the client. Take a minute to read through the list, and then if you'd like to print this out, it will be as an attachment to this lesson. Now that we've learned a little bit more about objectives, let's go back to our example that we've been using, where the problem was the client saying, I'm not sure I want to stop using drugs. And we helped the client devise a goal in which the client said, I want to understand all I can about addiction over the next 3 months so that I can stop, or that I can make a decision about stop using drugs or not. So in discussing how the client might go about gaining this understanding, we might talk to the client about different ways of doing that. and in the end decide that the client will explore the advantages and disadvantages of using. And so we can create 2 objectives this way. We can help the client identify 7 consequences of continued use, and we can also create an objective with the client of exploring 7 consequences of sobriety. So in this way, the client has an opportunity to look at the pros and cons of continued use as well as sobriety. If we take a look at this objective from an analysis of using a SMART objective, we can see that both objectives are specific. They're measurable because we can count it. It's achievable, and achievable is really based on the client telling us it's achievable. The client has to be willing to commit to this action, and then it's relevant because it's for a current problem and it's timely. We've identified a time frame over the next 4 weeks. Here are some examples of objectives that could be written that are specific, measurable, achievable, relevant to a client's problems, and timely. In the first one, where the client will list 3 12-step meetings that are convenient in terms of schedule and location by the end of the month, it identifies a measurable goal, a measurable objective, which is list 3 meetings. It's relevant because in this case, if the client is trying to determine pros and cons, they may want to attend 12-step meetings to find out more information. And it's timely because it's a 30-day, perhaps a 30-day obligation or step that the client can take. The second one is attending a 12-step meeting every other day. So that's measurable, and it's time limited over the next 4 weeks. The next one is about developing a list of 2 to 4 social activities that do not involve substance abuse. Again, it's measurable because it's a list of 2 to 4 activities, and it's time limited over 30 days. Research and print out a bus route. That's measurable. You can measure whether someone printed out a bus route. And the convenience is defined by the client who prints the bus route, and it's timely so that a person can get to their doctor's appointments. We could add a time limit identifying how much time a person would need to be able to do this research. And so based on what the client says, we would put in an end date there. Some EHR platforms already create a target date prompt to help you set the date. Here's another example objective where Sam is the client. Sam will identify and use a minimum of 2 methods or plans for remembering to take medication daily and as prescribed. The target date is 1 month, so 1 month from where you are now, and you would identify that in terms of like January 15th, 2020, or the specific date. So if we take this apart, we see that the amount that's required in an objective to make it measurable, in this case, is a minimum of 2 months. That's countable. The frequency is where the client is going to take his medication daily and as prescribed. And the duration is that month, day, year. The objective should contain a target date, and the amount of time you and the client think the client needs to accomplish that objective will become the target date. And it has to be specified as month, day, year. When we look at some of the do's and don'ts for writing measurable objectives and their timeliness, I want to make a point here. In some of the earlier examples, we saw that the objective said in 4 weeks or 1 month, and the reason for that is because sometimes when you're using an electronic health record, it will identify or create a prompt for you to specify a specific date, like month, day, year. However, if you're having to handwrite a plan or do a written documentation, then you will need to specify the month, day, year yourself, and you may want to either add that date when you're saying 1 month, or eliminate the 1 month reference and just use the date, month, day, year designation. Other things to keep in mind is that measurable objectives don't say PRN. It has to be specifically when it will occur and how it's going to be measured. Also, you don't want to say as needed, because that's not very measurable. And if you use ranges X to Y times per week, you need to be a little bit more specific than that, and either settle on a time like 3 times a week or 4 times a week rather than a range. Now we turn to the part of the service plan which identifies what you, the case manager, are going to do to assist the client. And as we've noted before in earlier trainings, a client who is just starting with case management is probably going to need more assistance than one who has been with case management for a few months and is beginning to develop self-reliance and self-sufficiency. So as you start with a client, you may find that you are advocating more for the client and helping the client find resources and access those resources than you would near termination phase, because by that time you will have helped the client learn the routes of getting services for himself or herself. You may be asking, how much time does this take? And that's a good question, and in that case, Medicaid actually limits the number of cases any one case manager can have at a time. Adult case managers can have only 40 clients on their caseload, and children's case managers can only have 20 clients on their caseloads. If we go back to the example that we've been using throughout this lesson, we can now add interventions because we have a stated problem, we have the identified goal, and we have the SMART objectives. So to help the client reach those objectives so they will eventually reach their goal, a case manager might talk to the client about referring the client for substance abuse treatment with an agency counselor. And if the client is willing to do so, the case manager can make that referral. The case manager could also monitor the client's attendance to evaluate the client's progress. This doesn't mean necessarily that the case manager is going to do an evaluation of the therapist providing the service. It's basically the case manager monitoring that the client attends or has no-shows and finds out from the client what might be barriers to keeping appointments. American society places tremendous value on the freedom to exercise choice in everyday life. Therefore, the well-being of the client should be reflected in the service plan. Constrained only by access to resources, it is assumed that all adults have the right and responsibility to make their own decisions about where they live, what they do, and how they want to be treated, as long as these decisions do not infringe on another person's rights. For this model of case management to be effective, of course, people with disabilities need to continue to feel like members of society despite their disability status, as opposed to being subsumed by their illness or diagnostic label. If the illness is allowed to rob the individual of his or her personhood and all of the socially valued roles that accompany it, the patient role is often one of the few that remain. Let's take a look at additional interventions a case manager might engage in to help clients reach their goals and objectives. Brokering and collaborating is very effective. Brokering is guiding the clients to an appropriate community resource and doing follow-up to determine the effectiveness of the services that the are being linked to. So brokering can include identifying and coordinating with partners the client is currently working with. What comes to mind is a situation I know of where a case manager helped a client work out some difficulties with a landlord. Coaching clients in determining what community resources are appropriate to meet their needs. The case manager has to have a really good understanding of referral sources that are available in the area to be able to help a client make choices from those community resources. A case manager can coach clients on how to effectively access resources. Another example that comes to mind is case managers coaching clients on how to use the local bus system. At our agency, the bus route includes stops at our satellite offices, and case managers will walk a client through the bus route, the bus schedule, and how to get on the bus when it comes to the center. The case manager also offers referral information. This is a way to give the client choices again. And the case manager will follow up to ensure that the client has connected with those resources that he's been referred to, and then assist the client in contacting the resources and obtaining help from them as needed. In the beginning, clients might need a lot of help with this, and as the client becomes more self-sufficient, the client will be able to do this for himself. Collaborating is a major role the case manager plays. Collaborating involves getting feedback from the clients on the effectiveness of the resources they've been linked to and advocating with partners on behalf of the client. Collaborating is like the case manager's middle name. It's what we do every single day of the year, even without thinking about it. Collaboration is a deep collective determination to reach an identical objective by working with others to achieve shared goals. A case manager always advocates not only for the patient but also for the providers, the payers, and in some instances the employers to facilitate positive outcomes for the client, the healthcare team, and the payer. When a conflict arises, the needs of the client must be a priority. The case manager's primary obligation is to his or her client. With the ideal collaborative practice, the positive client outcomes of quality care will be achieved. Collaboration is key no matter what aspect of case management is your area of expertise. Collaboration is not an intersection of common goals, but sharing knowledge and building consensus. The most successful collaboration requires a leader. And since case managers are usually the one in the team communicating with every stakeholder, the case manager is a natural choice to be the leader. The case manager should retain oversight of the entirety of an individual's situation over time. This gives a valuable sense of continuity for the client, which is an important characteristic of any case management program. The case manager is often the first responder, addressing complex crises involving both environmental components and psychological components. For example, if a person with a psychotic disorder decompensates, he or she is often at risk for homelessness. Preventing relapse may involve directly supporting the holding environment where the client is, while preventing homelessness may involve temporarily removing the relapsing client from a stressful living situation. In such situations, the case manager may simultaneously be working with the client, collaborating with a psychiatrist, and consulting with families and residential providers. The transference and countertransference responses are often intense, and case managers must learn how to recognize and contain their feelings and attitudes in the service of the client. Boundary issues can be managed by using supervision, and case managers should set up regular supervision to discuss their cases, and also have time with the supervisor to review documentation requirements as a separate agenda. Let's take a look at the case management interventions that you can bill for on a service plan. First, you'll include that you conducted the assessment and that you are developing the service plan with the client. You can identify on the service plan an intervention for the services with the family. However, those must be clearly identified and clearly directed to meet the identified needs of the client. And what that means is that family members may have issues of their own, and they'll want to draw you in to help them with their issues, and you can't do that when your identified client is someone other than that person. So if a family member is also wanting services, think about referring them for their own case manager. And really, you should not be providing services to more than one person in a family or in a home. Another case management intervention is assessing the effectiveness of the service plan. All along, you'll be monitoring the client's use of the services that you're linking them to and assessing the effectiveness. Linking and facilitating, we've talked about that many times. You'll be linking the client with appropriate services and resources that are identified in the service plan, and this takes into account your breadth of knowledge about referral sources in the community. Advocating for the acquisition of services and resources to implement your service plan with the client, and you may have to represent or defend the client through direct intervention. Plus, you'll be conducting clinical care staffings from time to time in which you're meeting with either the client's treatment team or one-on-one with a psychiatrist, maybe a psychiatric ARNP, a health physician, therapist, teacher, attorney, guardian ad litem, or other professional who's directly serving the client. One thing you might want to think of too as you are gaining knowledge about referrals in the community is the idea that you will be attending some of the community resources. Like if there's meetings in the community, you'll want to attend those to see what they're like. There are NAMI meetings in communities, and you might want to attend one or two of those to get a feel for what happens so that you can explain to clients where the meeting takes place, who leads it, and general topics that are discussed in those meetings. You may also want to attend an AA meeting so that you can refer people to AA meetings with some sense of knowledge about what goes on in 12-step meetings. Continuing with case management interventions, which is basically the role and jobs of the case manager, includes coordinating the delivery of services as specified in the service plan with the help of the client's family, and natural support system. An example of coordinating services might be arranging for an Uber or other kinds of transportation, and taking into account the client's access to transportation, the client's family's access to transportation, and transportation resources that are in the community. Monitoring service delivery, we've discussed previously, and that is not assessing or judging the adequacy of service providers, but you're actually monitoring your client's ability to keep appointments, to use transportation to get to appointments. You're looking at the ease with which the client can access services and barriers so that you can address those with the client and make amendments to the service plan as needed. Documentation is so important. If there's no documentation, the service did not exist, basically. And what that means is that you have to document everything that you do with the client, with the client's input documented, your input documented, why things happened, why things didn't happen. If you call a client and you are leaving a message, you have to document that. If you go to their home and they're not home, You document that. You just document every single thing that you do with the client. And if you need assistance in learning how to document, it's a good idea to get with your supervisor. Let them read the notes that you're writing and take their guidance and criticisms so that you can improve your documentation. You will also do crisis intervention and support at times by assisting the client in crisis so they can get access to the necessary resources in order to cope with the situation. You're going to arrange for and coordinate aftercare services when it's time for discharge, either from a residential or an inpatient unit, and you can actually bill for that discharge planning if discharge planning is not already covered by the facility's per diem. What that means is that, for example, if a client is in a residential program and the residential program does not have discharge planners, then you would become the active discharge planner and you could bill for those services. Another example would be crisis units. They typically have discharge planners on staff, and that already gets billed as part of the services provided by the crisis unit, so you would not be able to bill for discharge services in those situations. You'll be participating in the client's individualized treatment plan development, perhaps with other treatment providers, and so whenever you are participating in those kinds of staffings or discussions, you can typically bill for those, and that should then be put on the service plan that you're working with the client. All billable services must be included in the service plan. Think of the service plan as the plan for care that everyone is looking at to describe the limits and the boundaries of case management services. Auditors will come in and look at the service plan and make determinations on whether or not your progress notes reflect progress towards the goals and objectives described in the service plan. Funders will look at the service plan to be sure that the services you're billing for are on the service plan. And quality care is dependent on the way the documentation reflects the plan as it's negotiated with the client. We'll talk more about that in a few screens. Your success is dependent on the team's success. You're the collaborator and you're the leader of this collaboration. So your success requires the work of the team, including the client support system, other healthcare and service providers, the fund source for the client, and other clinicians. There are limits to the service plan. The service plan should not list every service an agency provides, nor should the service plan list every service the case manager knows about. You may think it's expedient to list all the services a client could possibly use on the service plan just in case the client wants to use those services. But that's not really the purpose of a service plan. The plan is to identify the current problems. Remember, we were identifying how to state the current problems, not past problems, and definitely not future problems that we might anticipate. The service plan is about what's happening right now, real time. So what are the current problems and what are the goals and objectives to address those current problems, and then the interventions. What interventions can be used to address these current objectives? So it really doesn't make sense to identify services that the client is not using right now. We have to be ethical in considering what services will help the client attain his or her goal of self-advocacy and self-sufficiency. So let's stop and take a look at what fraud, waste, and abuse entail. Because when you put more on the service plan than what you plan to provide, or you put things on the service plan that you don't provide, you are potentially causing fraud, waste, or abuse. Fraud is an intentional deception to benefit a person or a third party. Waste is an overuse of service or practice, creating unnecessary costs. And abuse is improperly providing a service or excessively providing a service, willfully or intentionally. Let's take a look at that. Fraud is when, you've heard this in the news, where you hear about people frauding Medicaid or Medicare. And they're creating clients that don't exist. They're billing Medicaid or Medicare for services they didn't provide. That's obviously fraud. We can all agree. Waste is like an overuse of a service or a practice that creates unnecessary costs. Where that would fit into your service plan is if you have the client continuing to receive case management services when they clearly are able to link themselves to services and arrange for their own services, and they don't need a case manager anymore. That's like overuse of a service. Improperly providing a service or excessively providing a service is when you are continuing perhaps to go out to a person's home and meet with them, and you're billing for that time and they really don't need it. You do have to meet with the client at least once a month, and probably more so at the beginning of the case management relationship. And as the person becomes more self-sufficient and settled and their goals are being achieved, you'll meet with them less. But if you continue to meet with them on that rigorous schedule as you do at the beginning of the relationship, then you might be excessively providing a service. This information was taken from the news headlines. Case manager, social worker caught in $160,000 Medicaid scam. A Florida couple were recently nabbed in a Medicaid fraud scheme that netted them $160,000. They were arrested for billing Medicaid for $160,000 in fraudulent charges. The couple were engaged to be married, and authorities charged the social worker and the case manager for billing Medicaid for services they did not perform, and the two created false documents and submitted them to their employer and to Medicaid. In some instances, the two billed youth for therapy sessions at a rate of 2 to 3 times weekly when they only performed the services 2 to 3 times monthly. They often billed for sessions during months when families had not requested services. For one child, they billed more than 900 hours of services when they only performed 100 hours of services, according to the news article. Here's another one. Deception in social worker. A social worker in independent practice provided services to a struggling adolescent and their families. One of her clients was referred by a local school, and according to school personnel, the student was sullen, withdrawn, and experiencing significant academic problems. The school's vice principal told the social worker that the student was very upset because her mother was recently sentenced to prison for drug dealing and her father was having serious psychiatric problems. Based on the strict criteria in the DSM, the Diagnostic and Statistical Manual of Mental Disorders, the teen's clinical symptoms were not serious enough to qualify for coverage by the state's Medicaid program, which provided health coverage to the family. To qualify for mental health benefits, the social worker would need to exaggerate the student's clinical symptoms. Social workers and you case managers are obligated to avoid any knowingly dishonest, fraudulent, or deceptive activities. Such activities not only undermine professionals' individual reputations and credibility, but they also harm the entire profession's reputation and integrity. It is vitally important for all practitioners, therapists, social workers, case managers, psychiatrists, and the like to have confidence in our practice, veracity, and trustworthiness. The reality is that instances arise when practitioners may be tempted to shade the truth to some degree. Dishonest, fraudulent, and deceptive activities can take several forms. You may feel pressure to exaggerate a client's clinical symptoms, particularly when such deception may be necessary to enable a vulnerable client to receive services. Think about that. Practitioners understand that they should not falsify records or documents with inaccurate information. However, despite this understanding, some practitioners may still feel compelled to falsify their documentation. Deception can take other forms as well. A person may exaggerate and make misleading claims of effectiveness, so be careful about that. We don't want to tell our clients that going to a 12-step program is going to guarantee their sobriety. We also need to clarify with our clients who we are. If they start to call you doctor, we need to clarify that really quickly to let them know we are not a doctor, unless of course you have your PhD or your MD or your DO or you are a doctor of some sort, and clarify who you are and what your credentials are. Let's take a look. Minimizing fraudulent and abusive behavior in the behavioral health care is so critical. Fraud and inappropriate provision of services will harm consumers, jeopardize the integrity of the system, and jeopardize clinicians and case managers working within the system. So again, what is fraud and abuse? Fraud and abuse is when a person knowingly cheats or is dishonest. The dishonesty results in a benefit such as a payment or a coverage. Examples of fraud and abuse by a provider is when the provider's credentials are not accurate. A provider bills for services which are not rendered, or a provider performs and bills for services which are not medically necessary. Recommending a service for which the consumer or the client did not meet eligibility requirements is also an example of fraud. So, for example, Medicaid has the appendices that you have to complete to show that the client meets the criteria for Medicaid case management. If you fudge those requirements, then you are committing fraud. A lack of monitoring progress to determine ongoing service eligibility, i.e. the assessment does not support and was not updated to support medical necessity for the services provided and billed to Medicaid, or maintaining a client in a service for a protracted period of time without measuring progress is also fraudulent. Failure to fully inform clients of changes in service provision can be fraudulent. Billing and being paid for more units of service than what was documented in the service record is fraudulent. So if you bill for services but you don't document them, that's a problem. Transferring all your clients all at once from one service to another within the same agency without regard for clinical appropriateness is also a fraudulent practice. Think about it. If you don't have an authorization to provide the Medicaid case management services to the client and you still provide those services, that's fraudulent practice. Pay sources identify processes to authorize services, and your utilization management department will obtain those approvals for you. But if you go forward and continue to provide Medicaid case management services, either after those units have been used up or they've never been authorized, you are creating a fraudulent practice. If you don't have a service order, or you don't have a diagnosis attesting to medical necessity for the services you're providing. That also is a problem. Either no valid centered service plan or not having the plan signed by the client or the legal guardian or not having your signature on the plan is also a fraudulent practice. Also, these plans have to be signed by your supervisor, and not having that plan signed by the supervisor and letting it go and not getting the signatures is also a fraudulent practice. The plans have to be individualized, and if they're not, and you leave them in a cookie cutter fashion as the electronic health record may create it, that's a fraudulent practice. It is important to have all relevant parties sign and date the service plan. That means you sign and date it, the client signs and date it, the client's guardian would sign and date it. If the client is a minor, his parents would sign and date it. And this not only creates buy-in by the client, but it also executes the plan from an administrative point of view. In some cases, a person who has legal authority on behalf of your client will have to sign the document, as in a guardian or a parent. Your signature as the case manager is required. Your supervisor's signature is also required. And you have to add a note to the client chart if a client and his legal guardian refuse to sign. You need to explain why the person refused to sign and what might take place at the next meeting to discuss the plan again with the client, to either amend the plan to get the client's agreement, or to review the plan with the client to make sure that they have an understanding. Maybe they misunderstand something about the plan that you're trying to communicate. Each client must have an individualized service plan written within 30 days of initiating case management services by the mental health targeted case manager or case management team. And the service plan must include measurable short and long-term goals for the client and must outline a comprehensive strategy for assisting the client in achieving those goals. The process of the service planning with the client has to be documented in a progress note. And additional progress notes while the service plan is in place should demonstrate progress towards those goals and objectives. Progress should be clearly identified and specifically related towards the plan's goals and objectives. Using general terms like minimal progress made, some progress made, moderate progress made, do not convey the specifics the client is achieving and should not be used. Documentation must clearly reference each separate billed service, have beginning and end times, and identify the location where the service is provided. The date of the service also must be included. Service plan reviews should document progress related to the goals and objectives. It's very easy to identify Goal 1, Objective A, Goal 1, Objective B, and then talk about the progress made towards those goals and objectives. These are typical errors found in audits of service plan documentation. The service documentation must be written and signed by the person who provided the service. It is not permissible to conduct a service plan session with a client and then have somebody else on your team write up the progress note or even write the service plan. If you conducted the service plan with the client, you must sign it. The content of the note must relate to the goal in the plan. At least one goal has to be addressed and at least one objective has to be addressed in your progress note. The service documentation must reflect the requirements of the service definition. So if you're identifying that you're going to link a person to some services, that note should reflect what you did to link the person to those services. Service documentation must reflect services for the duration of the services billed to Medicaid. So if you indicate that you went to the home and you spent an hour at the client's home with them, your progress note should identify what took an hour of your time and what was discussed It will not do for you to spend an hour or bill for an hour of service time and say that you went to the home and talked to the mother shortly and left. That's not an hour's worth of time. Service documentation must reflect the required elements. Your documentation should identify the purpose of the service that was provided, the intervention that was provided, and assess the progress towards goals. Let's summarize. Services must be rendered as prescribed on the service plan. The service plan must be authorized in writing by the case management supervisor. Parents and guardians must sign for minor children. It's okay to have the child sign, but it's their parent or guardian who is the legal signature. Service plans without a client signature or a signature from the parent or guardian for the minor child requires a note in the client chart documenting why this is so. Be clear about your role as the case manager as you write the plan. Establish dates for reviewing progress and the method of contact between the case manager and the client. Update the plan as needed by the reviews documented in the progress notes. Substance abuse plans must be updated monthly, and mental health plans must be updated at least every 3 months or when significant changes occur. This ends the training on goal setting and creating the service plan with the client. Please take the test and remember that a passing score of 70% is required.